I'd just like to say thank you so much for BD for having me here, and for everyone for coming. And I hope you all had a very good lunch as well. I hear it's a bit of a walk. As Letitia just said, my name's Emily Larsen. I'm working with the Avatar group, of which I'm not the director. Claire Rickard is the director. My main role within the Avatar group is to project manage or to work as a clinical trial coordinator for particularly randomised controlled trials and a couple of other studies, say cohort studies, qualitative studies, different things that are going on within the group. So today I'll be talking about developing research in vascular access, the who, the what, the how, and the why. And as my background is nursing, I tend to have a little bit of a nursing focus. I'm sorry for all of the multidisciplinary in the group. So what is Avatar? So really, the main goal of Avatar is to make IV complications history. And I think for everyone here, the reason why you're here is that this is the dream. We want to make vascular access devices comfortable for patients and have them last just one device for that one patient through that one admission. So let's talk about the why of vascular access research. So we know that peripheral IVs fail in about 1/3 of the time, so about 30 to 35% of them will fail. This actually can be as high as 50 to 69% in some of the published literature out there. So it's fairly significant, and the long-term impacts of this failure, it's not just about the short-term phlebitis or even the short-term pain. The potential impact of this on these patients and the loss of vasculature over time can really impact them. So why are these IVs failing? So it may be related to occlusion, infiltration and extravasation, dislodgement, phlebitis, and infection, and that includes both local infection and central line-associated bloodstream infection. So Nicole Marsh has recently done a systematic review, and Professor Claire Rickard will be talking about this in a little bit more detail later. And the failure worldwide seemed to be sitting at about 36%, which really is quite significant. And this isn't just in peripheral IVs, it is also in our central venous access devices. So we know that the failure rate for them is sitting at about 25 to 30%. Now these are significant devices also. We are talking about peripherally inserted central catheters, cuffed catheters, totally implanted ports, and the central venous lines that you find in ICU. Now, for the purposes of this talk, I tend to talk a little bit more about PICs, just because they are used a little bit more in our medical surgical areas around the hospital and a bit more common just in the general hospitals. So when we're talking about CVAD failure, the modes of failure are fairly similar, but there are differences naturally because of where the devices are placed. So infection is a very serious consideration when it comes to central venous access devices also, and again that's related to both central line associated and local infections. Occlusion tends to be what we find as the highest reported complication within particularly PICs. And this may be related to a failure to be able to withdraw blood or to administer treatment. This is usually closely followed by dislodgement as the second most common type of failure, and this may be partial dislodgement where it just comes out of the optimal placement within that lower third of the SVC, or it could be a complete removal. And particularly with patients receiving outpatient care, we find that dislodgement can be quite common, and again it's related to those lifestyle issues. So this is also, venous thrombosis is also quite a serious complication, and there's quite a bit coming out nowadays about whether or not it's appropriate to remove based on a venous thrombosis if it's only superficial as opposed to deep, because the chances of then going on to have a secondary device and that failing from thrombosis is almost guaranteed for these patients. So let's talk about the how of the whole thing. So how do we do vascular access research? Now, this is the hierarchy of evidence, and there's a little bit of to and froing between these different studies based on how well they're done and to what degree and how many people are in them. But this is generally how it is. So At the bottom, we have editorials and expert opinions, followed by case series and case reports, followed by case control studies and cohort studies. And then we have that top tier there, which includes randomised control trials and systematic reviews. Now, as a general rule, what we find is that the cost of actually undertaking this research does tend to increase as you go up that hierarchy. So naturally, a randomised control trial is going to be significantly more expensive than editorials, but then the level of evidence and the quality that you're getting out of it also significantly increases with that. Systematic reviews is a little bit of a different case altogether, in that it doesn't necessarily have to take the amount of time or money that randomised control trials have, but you do need to have a body of randomised control trials to have that systematic review make a real difference and show something significant for improvement. So I'd like you just to take a moment to think about your own facilities and your own situations and think of one topic in which you think, based on your experience, could improve in some way. And if you can follow this process as you're thinking about that particular way that you'd like to improve your process, I think it'd be good just to give you a bit more clarity at the end of it. So we want to, and I might have to read this one, sorry, find inspiration and develop a research question. And many of you have probably already done this within your own clinical practice. So in a perfect world, we would have perfect dressing and securement, beautiful clean lines, nicely inserted, followed by guidelines. But unfortunately, while the perfect world looks like this, the real world sometimes looks like this. And this is my face. So you can clearly see that while you may give nurses the tools to be able to care for these devices appropriately, the actual reality of them applying that appropriate evidence and being able to do what they're supposed to do may not necessarily come to pass. And sometimes this either may be due to a lack of knowledge, or sometimes when you become overly complacent with these devices, if you're used to seeing them over and over again with no complications, you lose that respect for these devices. So that respect is truly important. Okay, so when you're finding this inspiration, it may be complications that you can see, and you can walk around a ward and you can look at these patients and say, I can see that there are dressing and securement issues. I can see that the patient has obviously applied his own Band-Aids because the dressing was lifting, or there's been some sort of blistering from a medical adhesive skin reaction. That it might be bleeding, particularly within our oncology and hematology departments. We find that this is a significant issue, and for this reason they need multiple dressings, and this is where things start to go wrong too. You might also have dermatitis or local infections. For peripheral IVs, you might see visual things again, so you might see bruising, poor dressing and securement, phlebitis. So those are things that you can see, but what about the things that you can't see? This actually takes a little bit more work. So assessing for occlusion, either partial or complete, actually requires a little bit of knowledge as to how you're going to treat these things, whether or not they're reversible complications or not. Central line-associated bloodstream infection, again, is something that you may not necessarily know has happened until it's far down the line and it's come back from an infectious diseases consultant that, hey, this has happened, 2 weeks ago. Venous thrombosis, again, would need medical imaging. So to be able, while the visual things you might be able to walk around and notice are a problem, for something like this, you really do need documentation and some sort of way of reporting this long term to make sure that you are capturing these events. So the next process that you would go through when you're thinking about developing vascular access research is establishing what is already known. And we're very lucky that we do have the ability to find things from multiple sources. So the first place that I would always go looking is the Cochrane Library. So this is a library of very rigorously conducted systematic reviews that compile randomised control trials on a particular issue and are able to conclude, based on the bias, based on the sample size calculations, whether or not there is enough evidence to be able to support a certain process. There are also many different articles out there, randomised control trials, cohort studies, everything that's on here that you can find on Google Scholar, CINAHL, or Ovid Medline. So when it comes to looking at randomised control trials, we're very lucky to work with Mari Takashima, who's done a lot of work where she was looking at randomised control trials related to peripheral venous access devices. And she spent the time going through all of the randomised control trials within that topic and found that there were 128 that related to peripheral venous access devices. Now, this included midlines and arterial lines, 94 of which were just peripheral IV catheters. And they found that, the group found that the majority of the RCTs that were included related to the insertion of these devices, where we actually find that is only those few moments at the beginning of that life of the device. And what we need to be thinking is about care and maintenance, appropriate removal, and everything that follows that insertion. Not to say that insertion isn't important, but there's a bigger picture. Again, with central venous access devices, Mari Takashima actually conducted a scoping review of those as well and found that there were 178 randomised control trials related to central venous access devices. 38% of these actually related to insertion again, and this was followed by occlusion management and then in smaller amounts infection prevention, education and dressing and securement. So when you have this question, when you've got your inspiration, when you've looked at the evidence that's out there relating to that topic, could you then go back to your own facility and look at your policies and procedures and think, is this related to the policy and procedure? Are we comparing apples, which is the evidence out there, versus oranges, which may be your guidelines? Or do they actually align and it may be related to the nursing application of these guidelines? So you're actually looking at the root cause of what's perhaps going wrong within the facility. Next, I would look at planning an intervention or quality improvement activity. Now, this, when I talk about an intervention, this is more related to research where you might implement or conduct a randomised control trial, something like that. Whereas a quality improvement activity, it might be something that was already going on in your hospital. It might not necessarily be research, but something that you want to see what impact it's had over time. Now, what we find is that randomised control trials, where they have quite a lot of ethical considerations and you have to go through a lot of paperwork, they're quite expensive. A quality improvement activity within your own with your own facility might actually only require an exemption from ethics to be able to say, I just want to go and look back on the impact that a certain intervention at some point has made on my facility. So here's when you would plan the who, what, when, where, and how of the intervention. And so it's good to start with a very clear plan about how you're going to do it. What are your methods? Who are you looking at? What are your outcomes? Because when you have that clarity, it just means that the thing that you started to look at is really what you're going to have the outcome for later, as opposed to losing your way. So, as I said, randomised control trials can be fairly expensive. So sometimes, and the paperwork can be fairly arduous. So sometimes if you're just looking at getting started, it may be a case of a quality improvement activity to just understand what is going on to begin with. So I'm just going to give you an example of something that was conducted at my own facility in Brisbane, Queensland, very recently. And this was the findings of an observational cohort study. So what they've done is they've introduced an ultrasound machine. They were replacing their old ultrasound machine. They're a nurse leg pick insertion service. They brought this machine in anyway, but the lucky thing about this was that they actually had a database or an Excel spreadsheet that was already collecting information on every device that went in and the outcomes of those devices. And you, within your own facility, may already have these Excel spreadsheets available to you. You might already be collecting your own outcomes without actually knowing that you could use that data for something really good in the future. So they looked at first-time insertion success and device failure, and it was really just using what data they had already. And over that time, they had collected data on 500 PICs. So what they found was that first-time insertion success was 86%, insertion failure altogether, so they couldn't actually get the device in to the appropriate tip positioning, and they also, that was sitting at 8%, so only 92% were really being appropriately placed, and then total device failure was sitting at about 20%. So it seems like while their device failure rates actually fell under what we would usually expect, their insertion failure was still a little bit higher than what we would expect. So we would hope that for nurse-led PIC insertion services that this would sit within about 95 to 100%. So here you can see that even using your own local data, existing databases, you can see that perhaps they need to be looking at their insertion processes to be able to make some progress. So engaging key stakeholders, this may come after you've started planning the intervention, or it may come before, but it is very, very important because there are going to always be roadblocks in the way to improvement. It's just the nature, I think, of within particularly a healthcare culture where the change is scary. The impacts that it could potentially have on patients could either be positive or negative, and that unknown sometimes prevents people from really making positive change. So key stakeholders may include senior executives, it might include safety and quality, or it might be the patients themselves. You might want to consult with them about whether or not they actually like the intervention that you've planned. So within the Avatar team, we are very lucky to work with a large group, and so the investigators that we get involved fairly early also may perhaps include microbiologists. They might include people with particular qualitative methods that they're able to bring to it, so they can then look at patient satisfaction and the bigger picture for the patient. And they also have the opportunity. We also have the opportunity to have knowledge translators involved with the team as well, and I'll talk about that a little bit later. But I think the focus always needs to be on the patient. So, testing your intervention or activity and assessing the outcomes. So I'm going to give you an example of a pilot randomised control trial that was undertaken in 2016 and published in 2017 by Raymond Chan, based in my facility at the Royal Brisbane Hospital. And just show you how you can then take the results of something small and make it into something big. So the Cascade trial was looking at establishing the feasibility of a randomised control trial comparing 4 different dressing and securement methods for peripherally inserted central catheters. So, and this was a question that came up before, I think, from Juan on the left, who'd been asking about dressing and securement for PICs. So I'm hoping that this, the results of this study eventually will be able to feed something good here. So we were also looking at all-cause device failure and central line associated bloodstream infection. So we only conducted this study at the Royal Brisbane and Women's Hospital. We looked at medical, surgical and cancer care services. It was an adult population, so more than 16 years of age, that were planned for a PIC insertion, were expected to be an inpatient for more than 24 hours and had informed consent. We excluded them if they had a bloodstream infection, were non-English speaking, had diseased, burned or scarred skin, just because of the risks of introducing an unknown dressing product to them, and anyone who was at high risk of skin tears. So there were a number of proposed interventions, and we ended up with 4 in the end. So the one on the left-hand side that you can see is our standard dressing within the hospital at the moment, where it was a simple polyurethane dressing with a sutureless securement device and a biopatch. This was then compared against an integrated securement device, with a biopatch. A simple transparent dressing that had glue applied to the insertion site and then below the hub, And finally, it was compared against a polyurethane dressing with an absorbent lattice pad. And this was particularly interesting for those who had cared for cancer care services patients, where they often have clotting issues and may need that additional support to soak that up before the next dressing can be done. So what we found was that the PICC failure rate was immediately very high in the absorbent lattice pad, and that intervention had to be discontinued almost immediately. It was the dressing functioned in a way that two polyurethane dressings were actually applied against one another around the hub, and they were finding that it was very difficult to take the polyurethane apart, and so nurses were bringing out scissors to be able to cut, and you don't want scissors near a PICC. So that was discontinued very early. And these are some of this is some of the learning that occurs as you're doing research, is that you'll very quickly identify if something's not going to quite go right. So we then found with the tissue adhesive that although the failure rate was quite low, the patient satisfaction and the staff satisfaction was also low, because the glue would attach very strongly with the hub or the wings of the device and was difficult to remove. So the conclusion from that was that this would perhaps be used better for hemostasis at the insertion site as opposed to securement. Two of the arms went very well, so it was the polyurethane dressing with the sutureless securement device and the chlorhexidine dressing, and the integrated securement device with the chlorhexidine dressing. So this integrated securement device didn't actually need a sutureless securement device with it. So what did we decide? So as I've gone through, and one of the other interesting things that came along from this was that skin reactions were observed to be very high, and until this point we hadn't realised the rate of skin reactions, and we hadn't realised what an impact this was having for patients. And so this again is one of those examples of how you really don't understand what impact these interventions are having until you look at it as a whole. As a nurse, you may look after your few patients during that day, and you get to see just a fraction of the view of the entire hospital of what's going on. And a specialist could perhaps come through, look at the entire hospital and see that this was a problem. But unless you have that set of eyes looking upon every single patient, it's difficult to get that broad view. So if the Cascade trial was the feasibility and we knew that two of the arms were working, this was the opportunity to jump into a large randomised control trial. And Professor Claire Rickard was successful in gaining a grant from our national granting body, the National Health and Medical Research Council, in being able to make this dream a reality. So we then went on to start the Pisces trial, where we're comparing those two arms that went well within the pilot trial work, the sutureless securement device and the polyurethane dressing, and then the integrated securement device. And then the difference with this now is that we're actually looking at it with and without a biopatch, because when we actually went to, when Claire had gone to the Cochrane Library, and with one of our colleagues, Amanda Ullman, she had recently undertaken a systematic review that looked at dressing and securement of PICCs, and had found that, of CVAD, they'd found that PICCs, there wasn't very much evidence behind the use of chlorhexidine dressing. So this was a good opportunity to fill that gap as well. And this is a work in progress. So this work started at the beginning of, in the middle of 2016, and is expected to continue for another 2 years. But this is actually just within an oncology and haematology population as well, and it includes outpatients. So we're hoping to really answer that question of what is the best dressing and securement within this population. So assessing outcomes within research is very important as well. So it's not enough just to implement something and see how it goes. You really need to know what impact it's had, and this needs to be rigorously done and in a consistent fashion. So the benefit of a research nurse or somebody dedicated to a trial, or a team dedicated to a trial, is that those outcomes can be consistently collected, as opposed to perhaps decentralising that work and having nurses on the wards collecting that data. So it'll come back to the type of study that you're looking at as to whether or not that's appropriate or not. And this is an example of one of the ways in which we collect data. It's called the REDCap database. I think it's actually free to access, but ours comes from Griffith University, but it's gaining a lot of popularity in terms of data collection for research. So sharing results and translating it into practice. Now, I would argue that as much work goes into randomised control trials and coordinating them and collecting the data and then going through all of the data, sharing these results and translating them into practice can really be the war and the randomised control trial, the battle. So sharing the knowledge, not so hard. So you can actually use social media to get the word out, conferences, certainly publications, contacts, just to make sure that the findings of your work aren't siloed to your own hospital. It really is important that the learning that occurs in your individual hospital is felt by others, because we don't learn as an individual hospital. Really, we go it's a lot more of a slow process if you're only learning from your own experiences, because surely another hospital is seeing similar things or has seen similar things to what you're seeing. So knowledge translation, and this is fairly new to me. This is defined as a dynamic and interactive process that includes the synthesis, dissemination, exchange, and ethically sound application of knowledge. And this is to improve health, provide more effective health services and products, and strengthen the healthcare system. Now, that's a lot to do. It's a fairly short definition, but what's involved in that is significant. And this is really where engaging your key stakeholders early makes a difference, because to be able to do this, to be interactive, to disseminate this, to exchange knowledge, and actually soundly apply this, it really relies on their help. So it is not enough to create knowledge. It is not enough to create knowledge, i.e. the research, distill knowledge, or disseminate knowledge. This knowledge must be used. And so it's really, really important that if you perhaps have that database that you've been collecting on your own work that could perhaps be used to improve things for the future for others, perhaps it's time to get it out, have another look at it, see if there's anything that needs work in your own facility, plan that work, engage your key stakeholders, undertake the work, assess your outcomes consistently and appropriately, and share the work with others, and make sure that it eventually gets used in your own facility. So this is a quote from one of my favourite authors. So it's, "Please believe that one single positive dream is more important than 1,000 negative realities." And particularly with research, you will find that there is always opposition. There are always 1,000 negative realities, and it is really important to stay focused to that dream. Know that there are others who are struggling through the same thing and perhaps have already conquered that same hurdle, and it's time to perhaps take the time to make the dream the reality. So, thank you.